Hashimoto's thyroiditis. Is it a thyroid problem or is it an immune problem? I'm Dr. Martin Rutherford, certified functional medicine practitioner and chiropractor.
Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractor.
And Hashimoto's is a topic that we've covered before. Most of the time, we have I don't know how many hours we have online. I know over 400 hours, and I think most of the time we have the title of it has actually been subclinical hypothyroid or something of that nature, which is significant in that we did that because for the longest time, Hashimoto's thyroiditis was not taken seriously as a clinical entity. And most people who were searching for hypothyroidism. And then when people would watch the presentation, we would present that most of hypothyroidism is actually caused or is actually Hashimoto's thyroiditis, which is caused by the immune system. But now, and I will say, I want to give a shout out to Datis Karazian, who wrote the book called Why Do I Still Have Thyroid Symptoms When My Lab Tests Are Normal, as the one person, and although I have come across people who are diagnosed with Hashimoto's prior to him starting to do these lectures in 2002, but not many. And most doctors really never tested for it. But after he started to push it in seminars all over the country, people started to take it more seriously. And now I'm finding that most people who come in, well, maybe not most people, but a lot of people are coming in now already with the diagnosis of Hashimoto's. Mm-hmm. And but they're still coming in with their diagnosis of Hashimoto's because the therapeutic approach that they are endeavoring to follow is not working for them, and you're going to get a little bit of an idea as to why that is. So we're using the term Hashimoto's here so that now, because more people are now searching for Hashimoto's. Hashimoto's is, in my mind, very complex, and it is a major key and to many chronic pain problems. It's connected to so many things. I don't know if you're planning on going into that today, but it's really, I think, an expanding understanding of what's going on. I'm not sure that we know everything about it yet. Dr. Gates continually researches this topic because it's such a core to what we do. And what we do, for those of you who've never watched, and I have Hashimoto's, for those of you who've watched, you'll go, oh God, you got everything. And I do have Hashimoto's and have been through this as a patient and a clinician. But what we do is we do chronic pain, and we do all kinds of chronic conditions, and we've morphed a lot towards the neurological aspects of these conditions because we have started to understand how chronic stress hormones can affect chronic conditions globally across the board, and that most of our patients are like in fight, flight, or post-traumatic stress syndrome. Turns out that that's one of the causes of Hashimoto's thyroiditis. And so there's been this evolving understanding of what we're dealing with here. And so we share with you our findings from our clinical experience. The research is reviewed by Dr. Gates, and then he treats, and we do interviews, and we do histories, and we glean our data from that. And we're here to share this with you. So Hashimoto's thyroiditis, if you have it, if you know someone who has it, I don't normally say this, but I think you should have them watch this video because this is something that we work with every day, all day long. Would that be fair to say? Day in and day out, 5 days a week, 52 weeks a year. Mm-hmm. And it's complex. It's complex to even kind of semi-diagnose because you'll probably go into the numbers and how all over the place they are and symptoms but you can even, I've even read articles that say you can have antibodies and have no symptoms. So I guess before the damage is really done. And so it's a very challenging to diagnose it if you don't understand the full breadth of Hashimoto's. So Dr. Gates is going to help you to understand the full breadth of Hashimoto's because this is what he does all day long.
So I think it'd be good if we start at the core of the thyroid and then branch out from there. I think that will help people to understand. So we started doing broadcasts, like Dr. Rutherford said, on hypothyroidism. And some of those broadcasts had 50 plus research articles attached to them. We did them on subclinical hypothyroidism. Probably wouldn't be a bad idea to go back and watch them. But in summarizing these issues, it's just amazing how the thyroid affects so many different disparate aspects of your physiology. And thyroid issues can obviously range from people losing their hair, because it's predominantly a condition that affects females. It's very disconcerting for a woman to lose their hair. We hear a lot of our patients come in all the time, I'm losing my hair, I'm losing my hair. You know, and it's
the least of their problems.
The Titanic is really sinking at that point in their mind. So you can lose your hair, you can gain weight, you can be fatigued, you can be constipated, your voice can change. All of those variables, you can have edema in your ankles that most of us are aware of. But then we go into the literature, and as Dr. Rutherford is saying, they're doing research articles and they're seeing that females and patients can have all those symptoms independent of low thyroid hormones. And they're having those symptoms because their immune system is killing the thyroid, and the inflammation from the immune system killing the thyroid can create weight gain and hair loss, and it can be associated with all these other conditions like fatigue and brain fog. So that's a really, really important point to just kind of set the stage. And then when we started doing these broadcasts on hypothyroidism, you know, the data regarding hypothyroidism and miscarriage is just insurmountable. It's amazing. And it's something that every female should be aware of who's going into a pregnancy, to really make sure her thyroid is checked, but not just your thyroid hormones. And specifically, your doctor is going to run something called a TSH and a T4. T4 is inactive thyroid hormone. And they may run a T3, that's the active thyroid hormone. And just for a little bit of thyroid physiology really quick, TSH is the hormone that comes from the brain to the thyroid. When the thyroid is low, TSH goes up. So it's a inverse relationship to thyroid function, which confuses a lot of people. So I hope you can get that. If your thyroid's low, your TSH is high. If your thyroid is high, your TSH is low. And then the thyroid hormones, and primarily active thyroid hormone, feeds back to a part of your brain called the hypothalamus, right above your pituitary gland where the TSH comes from, to basically set the thermostat on your thyroid hormone levels. But going back to miscarriages, miscarriages are something that we want to try and prevent at all costs. And so you want to not only have your thyroid hormones checked, but you also want to have the immune counts run for your thyroid. And those are the thyroid peroxidase antibody level, as well as the antithyroglobulin antibody level as well. And we'll go into the values on that as we go through the broadcast. Now, as we delved into things like miscarriages, then the association with polycystic ovarian syndrome became pretty apparent as well. Many of you may know that as cysts on the ovaries. It can affect about 20% of females. It's almost a commonality that we'll be doing interviews with female patients, and they'll say, yeah, I was told I had cysts on my ovaries, but not to worry about it. And meanwhile, in interviewing the individual, maybe they have hair on their upper lip, or they have to wax hair off of their chest, or they have abnormal menstrual cycle lengths. If you have 2 out of those 3, cysts on your ovaries, excessive hair growth or high testosterone, and abnormal menstrual cycle lengths, then 2 of those 3 criteria, you have polycystic ovarian syndrome. And what were you going to interject?
I was thinking that maybe that might be a little clearer if we went back to, is it a thyroid problem or is it an autoimmune problem?
Relative to PCOS, I was going to tie that together.
Or I was just thinking relative to Hashimoto's in general.
Right, like, is PCOS a thyroid problem or an autoimmune?
No, it's like Hashimoto's an immune problem, or is it a thyroid problem? Or did we already do that?
I'm kind of wrapping that all together within all of this. Yeah.
Okay.
So with PCOS, they found initially that a lot of them did have hypothyroidism, but even a significant percentage had autoimmune thyroid disease. So they had Hashimoto's. But then that number started growing. So then it went to like 43%. PCOS patients had Hashimoto's thyroiditis. Now it's even higher than that. It's much higher than that. And so it's almost a 1-to-1 relationship, not completely, but that's almost how we look at it. Yeah, so it's very, very high in its association. And we're illustrating this because I want you, and we want you to fully grasp that this autoimmune issue to your thyroid can have far-reaching effects, because that's what most of you really need to get, that this is an immune system issue. And the immune inflammation is associated with a host of other conditions. So then we have Menieres disease. Menieres disease is a condition that affects balance and it can cause vertigo. And what they're finding is that the inflammation in the inner ear is actually commonly due to Hashimoto's thyroiditis. It's inflammation to the thyroid, and that inflammation to the thyroid then plugs the drain to your inner ear, which can result in vertigo. Another brand new study, they took a group of patients who had Hashimoto's, and they found that 62% of them have fibromyalgia. But what is fibromyalgia? That's where people have pain all over their body. They have significant issues with fatigue and brain fog. Commonly, they have depression. They have irritable bowel syndrome, just have trouble thinking. And so there's this big association now between Hashimoto's and fibromyalgia. So it just goes on and on. We see Hashimoto's associated with peripheral neuropathy. And the underlying factor is that the immune system has spiraled out of control. And when the immune system has spiraled out of control, it's attacking the thyroid most commonly first. So the thyroid, as the analogy goes, is kind of like the canary in the coal mine, where when the coal miner's down there, and if the canary dies, that means there's noxious gas, there's poisonous gas in the coal mine. So that told the miner they need to get out of there. Well, unfortunately, the thyroid is kind of the first organ to go when the immune system starts spiraling out of control. And we want this message to get out there that even if your thyroid hormones are normal, you can still have Hashimoto's thyroiditis. It's an incredibly prevalent condition. And not only can it cause all the symptoms of hypothyroidism, most of you are going to think of it in terms of like weight gain and fatigue, but it can really have profound neurological consequences, because they're finding these immune cells to the thyroid go into the frontal lobes where you think, where you control anxiety from. And they're finding that these antibodies to thyroid that go into the frontal lobe can also be associated with, it almost predisposes you to other immune cells that start attacking your frontal lobes in addition. So you can have brain fog, depression. Depression is a major,
very common
cofactor with Hashimoto's. And they're even seeing that blood flow decreases in the frontal lobes for patients who have Hashimoto's. Blood flow decreases in your frontal lobes. So if you have all these nebulous complaints that your doctors can't figure out,
migraines,
celiac migraines,
dizziness, vertigo, imbalance.
Celiac. They're even showing that non-celiac gluten sensitivity. These patients that are going into gastroenterology facilities, a lot of them have Hashimoto's thyroiditis. So starting with the thyroid as the core, you can see all these other branches going out that are involved with the immune attack on the thyroid. And by understanding that, maybe you have better clarity on your condition. Now, many of you maybe watch this broadcast, you may even be saying, well, my thyroid antibody levels were normal as well. My doctor told me they were normal.
Important.
Here's the next most important point, is that there's not a unifying, accepted, standard agreement in endocrinology as to what's normal and what's abnormal for the thyroid antibody count. For example, when I first got into practice close to 8 years ago, the high value used to be 100. Now, LabCorp is saying 34 is the high value for the thyroid peroxidase antibody. Mayo Clinic says anything over 9 is too high. And we have patients coming from Europe where they're saying anything over 5, 5.5, or 6 is too high. So you can see the discrepancy there. And it's the same unit of measurement. So it's not like it's a different unit of measurement to explain why it's so different. It's just that no one has really agreed on what that high value is. In our world, if you're over a 9, you have Hashimoto's. But again, we've seen patients from Europe that are at a 6 that have been diagnosed with having Hashimoto's.
And to add to that, not unlike rheumatoid arthritis markers and ANA markers for lupus and stuff, some days the antibodies are low. And so you take the test, and even if you are using a range of 0 to 5, it comes out normal. But if you have all the symptoms, the likelihood is that you have it because on that day it was normal. And then you could test it 2 days later, and it might be like 25. So that's another confusing factor, which is something that just doesn't seem yet to have kind of found its way into the general endocrine community.
I'm with you. I'm with you 100%. Because we've seen that time after time where patients come in, they're normal, and then I test them a couple months later and all of a sudden they have it. Well, they had it all along. It's just it wasn't showing up. So I think with that foundation, now you can kind of understand the far-reaching consequences of Hashimoto's thyroiditis. But just to kind of bring it back into focus, so many of you out there are searching thyroid. So many of you out there may have been told you have hypothyroidism and you're taking medications and you still feel like crap. You probably still feel like crap because you have Hashimoto's. Or a lot of you may think that you have a thyroid condition, but all of your thyroid hormone levels are normal. And maybe even your Hashimoto's markers are quote unquote normal, but you have to review it with a fine-tooth comb. In our opinion, anything over 9 is too high. And that's really the opinion of the Mayo Clinic. So that's really important too. And then a lot of patients then go to, well, what do I do about it? Well, what you do about it is the big dominoes that we've seen are foods. What most of the research is going to is that foods seem to have a causal factor or a component there to Hashimoto's thyroiditis, where when you're eating certain foods, are they getting through the intestines, and then the immune system is attacking those foods, and those immune chemicals that attack the foods, if the food looks like the thyroid, then the thyroid gets attacked. That concept is called molecular mimicry. Other research is going into Epstein-Barr virus and how a vast percentage of Hashimoto's patients seem to have Epstein-Barr virus in their thyroid. But just know the research didn't start with Epstein-Barr. It actually started with other viruses, because clinicians were seeing patients come in who had like herpes infections on their mouth, and then all of a sudden they developed Hashimoto's. So they initially did the studies on other herpes viruses. Epstein-Barr is a herpes family virus. It's a cousin, if you want to think of it that way. So there's that research as well. Now there's even more and more research going back to things we were talking about 7 years ago regarding Th1, Th2 dominances, Th17, Th22. Th stands for T helper cell. And when individuals have autoimmune conditions, what we find is that these basic 2 main sides of the military, the Th1 is kind of like the Marine Corps and Th2 is kind of like the Air Force, they can become imbalanced. And when there's immune imbalance, that can promote autoimmune disease to many different organs, including the thyroid. But there's this other guy called Th17. He's kind of like an evil dictator. And that definitely seems to be associated with Hashimoto's. And they're doing more and more research on the exact molecular mechanisms as to why your immune system breaks down, why your immune system eventually ends up killing your thyroid, when really it shouldn't. But another interesting piece of the literature is that the thyroid actually attracts immune cells to it when there's inflammation. And there's some thought that inflammation from the gastrointestinal tract, because of pieces of bacteria getting in or food molecules getting in, is promoting this inflammation throughout the body, causing the thyroid to get attacked. And we highlight this because now a lot of, I'm not going to say a lot, but current estimates by some accounts are that 1 out of 3 females have Hashimoto's. And it may even be higher than that when you use the Mayo Clinic criteria. So we have, it's almost a pandemic problem. And all you have to do is go and walk down in any supermarket or walk through the mall. And as a society, we have issues. We have chronic pain problems. 130 million people have chronic pain. Why are so many people in pain? Probably because maybe they're inflamed. Yes, there are other factors. People slip and fall and hurt their back. But 130 million people with chronic pain. And then we have the issue of weight problems in our society. 2 out of 3 people now are not in the normal weight range. And it's not because they're building muscle at the gym, it's because they're gaining weight excessively. And so Hashimoto's is part of that piece of the puzzle that you have to pay attention to. So when you look at these issues, this whole Hashimoto's problem is actually like a nexus, creating other health issues spreading out from it. And that's why it's really important that you watching this, or people that you love and you want them to learn this information, need to understand that this autoimmune thyroid issue is a autoimmune issue. Your thyroid issue is an autoimmune issue. You got to get that. And once you get that, you can start understanding why you've been told you're normal, and you can start understanding how to really start addressing this.
Yeah, if your doctor starts talking about, oh, I got to do this thyroid medication and so on and so forth, that may make you feel good for a while. But one of the most difficult things that I had to try to figure out, I try to learn how to communicate these things well to the lay public when they come in, because they usually have been taught kinds of places and they don't feel good. Like clinical pearl, if you're driving your doctor crazy relative to your thyroid, you probably have Hashimoto's. Okay. And so people come in, and 10 years ago, it was like 8, 9 years ago, that it was like, well, what do you have for Hashimoto's? Meaning, like, do you have another herb? Do you have another botanical? It was the hardest thing for me to be able to help that person understand that it wasn't the thyroid. It was all the things that Dr. Gates is talking about that are creating an attack on the thyroid. And it was funny, intuitively, after about 2 or 3 years, I thought, Hashimoto's is like the #1 autoimmune problem that there is. And another clinical pearl, if you already have an autoimmune problem, rheumatoid arthritis, or you have lupus, or you have any type of autoimmune problem, probably the second thing that's going to happen is your thyroid's going to get attacked. And then you're going to get all these thyroid symptoms. You're going to wonder why you're putting on weight and you can't lose it, and you're tired and you're fatigued. And it's like, well, your tests are normal. It's because they're not looking at it as an autoimmune problem. So they're not even doing, still, most of the doctors are not even still doing the autoimmune markers. That because they don't, because
what are they going to do? They're not going to give you anything.
Because it's not going to change your treatment. Right. So it's like, okay, why should I create another problem for myself by finding out that a person has Hashimoto's when I'm not going to change my treatment? Why are they not going to change your treatment? Because Mayo Clinic isn't going to change your treatment. As the Mayo Clinic says every year, we don't know what to do with these subclinical hypothyroids, code name Hashimoto's thyroiditis. And so right now, this model is the model itself is an impediment to the advancement of treatment for the thyroid, because the model is go in, get the test, take a medication when it's really an immune problem. Example, let me use one example before I wrap up my part. I had a patient come in here about a year or two ago, severe rheumatoid arthritis. Okay, she wanted to get off the steroids. First thing, remember when I said that the testing is, some days it's normal and some days it's not? I said, you have rheumatoid arthritis. And she had rheumatoid, I mean, her knuckles were red. They were broken down, her hands. She said, my doctor's not sure. I said, this is where we're at. The tests were normal, okay? Because autoimmune testing right now is still in its infancy. It's here, it's there, it's all over the place. So we did the interview, and we determined that we could help her probably to get the inflammation down and get her off the steroids. And she said, Dr. Rutherford, can I ask you a question before I leave? I said, yeah, sure. She goes, you know, I hear terrible things about steroids. I have been on them for like 3 months now, 4 months. And I hear you're supposed to get bloated and you're supposed to look really bad, but I've lost weight. My hair has gotten better. My skin is not dry. My constipation has gone away. My energy is much better. I said, oh, you have Hashimoto's thyroiditis. She goes, no, what's that? I go, it's thyroid problem. She goes, yeah, I got a thyroid problem. It's hypothyroid. I go, no, it's Hashimoto's. The point being, it's an autoimmune problem. She was given steroids to dampen or crush the immune system so that it didn't attack her knuckles, and it calmed down the immune attack against her thyroid. Right. And it was like, and she got it. And that's the only reason I bring this to you, to kind of bring you a practical application of it's an immune problem. Now, I'm not telling you taking steroids is a great thing to do for the rest of your life, especially if you don't have to, okay? And that's the whole point. The medical model doesn't know anything else that they would do for it. They still think of it as a thyroid problem, so they wouldn't even think of giving you a steroid for an autoimmune problem, which they would give you for in a second for MS or rheumatoid arthritis or lupus. So that's the ginormous disconnect that Dr. Gates is bringing here to you. It's that understanding that it is an autoimmune problem first. It may beat up your thyroid enough to eventually it's a thyroid problem, but it is first a autoimmune problem. It is an autoimmune problem. That's what it is. And you have to calm down everything that's screwing up your immune system. You got high blood sugar, screwing up your immune system. You got low blood sugar, you got stress hormones, you got food sensitivities, whatever you have, chronic viruses, whatever you have that's flaring up your immune system, that's what you got to calm down or fix to get your thyroid under control if you've been diagnosed with Hashimoto's thyroiditis.
And in my opinion, it sounds way better to address those. There is a little bit of new research where they're trying to use heavy-duty immunosuppressive drugs, biologics, like they use for rheumatoid arthritis. I didn't realize
they started doing that.
They just started doing some research.
Well, there you go.
But the idea is,
has been around since 1902.
But the idea is, what the alternative community is seeing is that this is an illness that lots of times you can really control these symptoms by doing these other factors, by addressing the viruses, by addressing the gut, by addressing food intolerances. Yes, a lot of you are going to read about selenium and vitamin D. That's all important too. But The gut and the viral issue is huge. And then figuring out why your gut is breaking down, which we usually find most of you, it traces back to a stress mechanism. It's very overactive. So yeah, as Dr. Rutherford said, the model seems kind of broken. The model right now is to check your thyroid hormones and make sure you don't have thyroid cancer. That's the model. We're not knocking that. It's good to make sure you don't have thyroid cancer. But a lot of you are going out there unfixed, having these symptoms, told you're normal, and you're really not normal. And if you have any question about that, you can go to powerhealthtalk.com, go to the bottom of the page. I attached 17 references to today. Every other thyroid broadcast has probably between 10 and over 50 references. We probably have cumulatively close to 150 to 200 references.
And for those of you who aren't overweight, by the way, we do have a presentation on the thin Hashimoto's patient.
Yeah. So I think that summarizes it. Anything else you want to say?
No. I got out what we needed to say.
Well, we will be back next week with another exciting broadcast. We'll see you soon.
Okay.